Welcome to The Debate. Imagine a simple maternal blood draw that is, so astonishingly accurate at detecting chromosomal abnormalities that it threatens to render decades of rigorous, highly skilled ultrasound training completely obsolete.
Obsolete basically overnight, yeah.
Right, overnight. I mean, for years we've relied on our eyes and our ultrasound probes to calculate risk. But modern medicine is shifting. We are moving away from looking at the phenotype,
What the fetus actually looks like.
exactly, the physical appearance, and we are moving toward the genotype, the raw biological blueprint. I will be arguing that universal cell-free DNA must be our first-line screening modality simply because the chromosomal detection rates are unmatched.
And I will be taking the opposing view today, because that shift to a purely molecular approach is exactly what we need to scrutinize. When you stop physically looking at the patient, well, you gain a very specific type of precision, but you lose the entire clinical context.
But the precision is the whole point of a screen, isn't it?
Not when you're evaluating a highly complex, developing human cardiovascular and lymphatic system. You aren't just processing a lab value. I argue that the integrated ultrasound combined screen has to remain our foundation.
Well, that brings us right to the tectonic shift we're unpacking today. We are looking at a profound divergence in medical philosophy regarding first trimester aneuploidy screening, specifically in that crucial window between 11 and 13 plus 6 weeks of gestation.
The golden window.
Right. So on one side, we have the new ACOG 2026 guidelines pushing heavily toward molecular testing. On the other, the established frameworks from international bodies like ISUOG and the Fetal Reticent Foundation who champion the traditional ultrasound approach.
It really comes down to one central question. In an era where cell-free DNA testing is incredibly accurate, should that universal blood test completely replace the traditional ultrasound-based combined screen as our primary gateway for risk stratification?
I look at the data and see a clear answer. Universal cell-free DNA has to be the primary gateway. It's time we fully embrace this paradigm shift.
But here is where that logic falls apart for me. I look at the exact same data and see that the combined screen, which incorporates precise structural markers like the fluid behind the fetal neck, the presence of the nasal bone, the blood flow near the heart, that has to remain the foundation.
Even with a blood test that is so much more sensitive?
Yes, because relying purely on a maternal blood draw for cell-free DNA gives you a fantastic read on 3 specific chromosomes, sure. But it is a dangerously narrow test. It is entirely blind to major structural pathologies that a skilled ultrasound captures immediately.
I hear that concern. I really do. But let's break down exactly how these tests work, because the mechanics dictate the performance. Let's look at the ACOG 2026 guidelines, which have rightfully elevated universal cell-free DNA to a primary recommendation.
Right, a grade 1B recommendation.
Exactly. When we draw maternal blood, we are capturing microscopic fragments of DNA that have been shed by the placental trophoblast cells. We are sequencing millions of these fragments to see if there is a proportional overrepresentation of, say, chromosome 21.
Which is brilliant technology, obviously.
It is. It works even when the fetal DNA fraction in the mother's blood is as low as 4%. Because we are looking at the actual genetic material, the performance is just staggering. We are talking about a 99.7% detection rate for Down syndrome with a false positive rate of just 0.04%.
Those numbers are impressive, absolutely. No one denies the sequencing is a marvel.
So contrast that mechanism with the traditional combined screen. With the traditional method, we are measuring maternal age, looking at the nuchal translucency, that fluid collection at the back of the fetal neck, and measuring traditional placental proteins in the mother's blood.
Which gives us a comprehensive risk profile.
But a noisy one. At its absolute best, this method achieves maybe a 90% detection rate, and it settles patients with a 3 to 5% false positive rate. In a clinic seeing thousands of patients, a 5% false positive rate means hundreds of terrified parents being told their pregnancy is high risk when it actually isn't.
Well, we can lower that false positive rate, which we'll get to.
Sure, but out of the box, it is clinically illogical to rely on highly operator-dependent ultrasound markers to guess at a chromosomal dosage when maternal plasma gives us near diagnostic accuracy. I always say using traditional markers to find Down syndrome when we have cell-free DNA is like using a stethoscope to listen for a hairline bone fracture when there's an MRI machine right down the hall.
Oh, I actually love that analogy. But you're misidentifying the disease here.
How so?
Because aneuploidy isn't the only fracture we're looking for. You're using your cell-free DNA MRI to perfectly diagnose a broken arm while completely missing that the patient is having a massive heart attack because you threw away the stethoscope.
Come on, thrown away is a bit strong.
But you are treating the 11-week scan as if its only purpose is a Down syndrome hunt. It is not. This scan is a risk-proportionate, patient-centered clinical evaluation. Cell-free DNA is phenomenal at counting chromosomes 21, 18, and 13, but it tells you absolutely nothing about the actual functional morphology of the fetus.
What the guidelines don't say, don't do an ultrasound, ACOG 2026 clearly recommends an early anatomical survey for everyone. I'm just saying the screening for the genetic condition should be done by the blood test.
But you can't neatly separate the two in practice. When you argue for abandoning the primary combined screen as the main gateway, you are actively encouraging clinics to sacrifice vital secondary ultrasound markers.
You mean the technically difficult ones?
I mean markers like tricuspid regurgitation in the fetal heart or the ductus venosus. These aren't just parlor tricks for aneuploidy. They are critical hemodynamic indicators. They alert clinicians to major congenital heart defects even when the genetics are perfectly normal. If you bypass the combined screen for a simple blood draw, you are blinding yourself to the functional reality of the fetal heart.
Okay, well, let's talk about the practical reality of that MRI versus stethoscope debate then. Because while cell-free DNA is a marvel, you're right that it isn't flawless. It has a failure rate.
Exactly. About a 2% failure rate, and we have to explain why it fails.
Usually low fetal fraction, right?
Often.
Yes. The amount of placental DNA in the maternal blood is simply too low to run the sequencing. And here is the physiological kicker. A low fetal fraction isn't just a lab error. It is, in itself, associated with a significantly increased risk of chromosomal abnormalities like trisomy 18 or triploidy. Because the placenta is so small and dysfunctional, it isn't shedding enough DNA. Right. So a non-reportable result requires immediate clinical action. You don't just shrug and tell the patient to come back in a month. You have to fall back on the ultrasound. I completely agree. A test failure is a huge red flag. Furthermore, the nuchal translucency measurement, which, by the way, has to be taken strictly when the fetus is between 45 and 84 millimeters long, that remains our mandatory clinical anchor. What happens when you have a vanishing twin? Ah, the vanishing twin scenario.
Yes, you have a pregnancy that started as twins, one embryo demised early on, and now its DNA is dissolving into the maternal bloodstream.
And the cell-free DNA becomes effectively uninterpretable.
Exactly. The sequencing machine can't tell which DNA fragments belong to the surviving fetus and which belong to the demised one. In those cases, you must rely on the ultrasound markers. The ultrasound isn't just an accessory. It is the entire clinical foundation that keeps the patient safe when the neat molecular test breaks down.
Okay, I'll concede that vanishing twins and low fetal fraction test failures are critical edge cases where ultrasound retains absolute primacy. But let's zoom out. Let's look critically at the reality of relying on these ultrasound markers at a population level.
All right, let's do that.
If the integrated ultrasound platform is going to be defended as the primary screen for the masses, we have to talk about the immense physical and technical difficulty of acquiring these images. Let's look at the nasal bone.
A fantastic marker when used correctly.
Sure, when used correctly. But there is a glaring tension right now between the FMF guidelines, which mandate nasal bone assessment, and the ISUOG guidelines, which classify it merely as optional.
Because it requires advanced training.
It requires near perfection, and there is a very pragmatic reason the international guidelines hedge on this. Think about what we are actually asking a sonographer to do in a high-volume back-to-back clinic. They have to find a perfect equal sign on a monitor.
It's challenging, but absolutely doable.
They have to identify a microscopic bone line that must be strictly more echogenic, brighter on the screen than the overlying skin line.
And they have to do this while maintaining a precise 45-degree angle to the bridge of the nose of a squirming fetus doing backflips in the amniotic fluid. It is incredibly difficult.
It requires rigorous training, yes, but our sonographers are highly skilled.
But when it is imperfect, poor quality assessments systematically inflate the false positive rate. We are asking operators to go through this grueling, highly subjective morphological assessment just to tweak a statistical probability by a few percentage points. Why force that burden onto the healthcare system when a simple blood draw is 99.7% accurate?
Because when that morphological assessment is done correctly, the physiological insight is spectacular. The reason we look at the nasal bone is because in fetuses with trisomy 21, the ossification centers, the areas where cartilage turns into bone, are developmentally delayed.
Right, the bone hasn't hardened yet.
Exactly. It simply hasn't hardened enough to reflect the ultrasound waves by 12 weeks. Adding that single observation to the combined screen cleanly halves the false positive rate down to about 1.5% without losing any sensitivity.
Still a higher false positive rate than cell-free DNA, though.
Yes, but you are right to bring up the complexity because it highlights exactly why deep human fetal medicine expertise is irreplaceable by a lab machine.
But if it's that complex, isn't it highly prone to human bias?
That is exactly why the clinical context matters. Let's talk about the physiological nuance of the nasal bone, specifically the mandatory ethnicity adjustment.
Right, the baseline differences.
We've known for over 2 decades that ossification baselines differ based on genetic ancestry. For example, if you look at perfectly healthy, chromosomally normal Afro-Caribbean fetuses, about 2.5% will have an absent nasal bone at this gestational age. Compare that to just 0.5% in Caucasian fetuses. It is a normal physiological variation.
And if a clinic doesn't account for that?
Disaster. If a clinical algorithm just applies a blanket European baseline to a diverse population, you systematically overstate the genetic risk for minority patients. You artificially inflate their risk profiles simply because of normal phenotypic variation.
Which is a huge flaw in relying on subjective imaging.
No, it showcases why you cannot decouple the screening process from expert clinical evaluation. The integrated ultrasound forces the clinician to look at the patient holistically, adjusting for ethnicity, maternal weight, and specific fetal physiology in a way that a binary genetic test simply doesn't care about.
I see the value in holistic care naturally, but your argument essentially boils down to we should keep a highly complex, highly subjective, operator-dependent system just because our experts have figured out how to mathematically correct for its inherent physiological biases.
I wouldn't call them biases, they are biological realities.
But if the nasal bone requires that much manual correction, that much pristine imaging angle, and that much demographic adjustment, it only strengthens my argument for cell-free DNA. The sequencing machine doesn't care about the angle of a squirming fetus's profile. It just counts the DNA fragments.
But counting fragments doesn't tell you how the fetal heart is pumping.
Which brings us perfectly to the next marker. Let's move from static moans to dynamic blood flow. Let's talk about the most technically demanding marker of them all, the ductus venosus.
My favorite vessel.
I know it is. The latest guidelines push for evaluating this tiny vessel. We are asking sonographers to place a microscopic 0.5 millimeter Doppler gate at the exact inlet of the vessel just above the umbilical vein.
It takes patience, certainly.
It takes a miracle sometimes. We need them to capture a pristine waveform to classify what we call the A wave during the precise moment the fetal heart's atrium contracts. From a purely resource allocation perspective, is it really justifiable to spend valuable clinic time chasing a microscopic Doppler gate while the patient coughs and the fetus moves, especially when cell-free DNA is already processing in the lab and will give us a definitively better aneuploidy answer anyway?
It is absolutely justifiable. In fact, it might be the most important thing we do at that gestational age. And I can give you a very specific clinical scenario that proves exactly why the blood test alone is insufficient.
Okay, let's hear the scenario.
Imagine you have a 31-year-old patient sitting in your clinic. Her ultrasound shows a completely normal nuchal translucency, perfectly thin at 1.7 millimeters. Her maternal biochemistry is totally normal. Her baseline combined risk is calculated at 1 in 1,200.
So she's low risk.
By every traditional metric, she is the definition of low risk. Now, If you just run your universal cell-free DNA test, it will undoubtedly come back negative for trisomies 21, 18, and 13. You will send her home with incredible reassurance.
Reassurance that our fetus does not have Down syndrome, which is accurate.
Accurate, yes, but potentially devastatingly incomplete. Let's look at the actual physiology of the ductus venosus. It acts like a funnel. Oxygen-rich blood from the placenta shoots through this tiny shunt to bypass the liver and get straight to the fetal heart.
Right. It's a critical pathway.
During the A wave, when the atrim of the heart squeezes, blood should keep moving forward. But what if our highly skilled sonographer places that half-millimeter gate and sees a reversed A wave? What if that blood is being pushed backwards?
Which that indicates the heart is struggling.
Exactly. If the heart muscle is stiff or failing, that atrial squeeze pushes blood retrograde down the funnel. Now, mathematically, that finding alone increases her trisomy 21 risk 5 to 10-fold.
True.
But let's say the cell-free DNA was right, and the genetics are perfectly normal. That reverse blood flow is an independent, glaring red flag for severe structural congenital heart defects. Universal cell-free DNA entirely misses the functional reality of that struggling heart.
That is a very powerful point.
The ductus venosus isn't just a chromosomal marker. It is a vital early warning cardiovascular indicator. If you dismantle the primary integrated ultrasound screen just to save clinic time, you are actively choosing to miss major cardiac defects at 11 weeks.
I mean, that is a highly sophisticated physiological point. I will concede that the dual-use nature of functional markers like the ductus venosus, evaluating both chromosomal and cardiac risk simultaneously, is the strongest possible argument for the integrated ultrasound approach.
Because we are looking at the mechanics of the heart, not just the blueprint.
Right, exactly. But we must also consider the endpoint of all this screening. We do all these tests to decide who needs a definitive diagnosis.
Right, the invasive testing.
Exactly. Regardless of whether a patient arrives at a high-risk designation via a reverse Doppler wave or a positive cell-free DNA result, the final destination is the same. It's invasive diagnostic testing. Chorionic villus sampling, CVS, where we biopsy the placenta between 11 and 13 plus 6 weeks, or an amniocentesis to sample the fluid from 15 weeks onward.
The only way to get a true diagnostic karyotype.
And here, I think we actually have a profound point of convergence in modern fetal medicine, specifically how we counsel terrified patients about the actual risks of these needles.
Oh, it is a complete paradigm shift. It changes the entire risk-benefit calculus for the patient sitting across the desk from you.
Precisely. Let's look at the history here. For decades, patients were utterly terrified of invasive testing because clinicians routinely quoted a 1 to 2% risk of procedure-related miscarriage.
1 in 50 chance you will lose a baby if we do this test.
Yes, and it was paralyzing for them. But recent massive meta-analyses, like the Akalakar data from 2015, have completely rewritten this narrative. We have to explain the concept of background-corrected risk.
It's vital we explain this properly. Miscarriages happen naturally in the first trimester, sadly quite often. Historically, if a patient had an amniocentesis and miscarried a week later, the medical community just blamed the needle.
Exactly. But when you look at massive modern data sets and carefully subtract the background rate of miscarriages, the ones that would happen anyway, regardless of the procedure, the actual isolated risk caused by the needle itself is minuscule.
It's incredibly low now.
We now know the procedure attributable loss rate is around 0.11% for amniocentesis and 0.22% for CVS. Clinicians are now instructed by bodies like the RCOG to quote a risk of less than 0.5%.
Which completely changes the conversation.
When a patient understands that the true risk of getting a definitive, perfectly clear karyotype is less than 1 in 200 rather than 1 in 50, their willingness to accept definitive testing changes dramatically.
I agree entirely with the data. The procedures are safer than we ever thought. But, I actually use this exact data to reinforce my core thesis about the ultrasound.
Oh, really? How so?
Because that invasive procedure risk is real. Even if it is safely below 0.5% now, it's not zero. We are clinically obligated to only introduce that needle into the uterus when the probability truly justifies it. This is exactly where a meticulously executed combined ultrasound outshines a simple blood test.
Wait, if the blood test is 99.7% accurate for Down syndrome, doesn't that justify the needle perfectly?
For the major trisomies, yes. But what if a patient has a borderline cell-free Deanna result, or a test failure? Or what if she's just incredibly anxious about a general baseline risk?
Well, we counsel them based on the lab results.
But if we have the full integrated profile, the nuchal translucency, the nasal bone, the heart valves, the ductus venosus, we can precisely calibrate that specific patient's comprehensive risk. We provide a richly detailed risk-proportionate justification for doing the invasive procedure.
I see what you're saying.
A binary cell-free DNA result of high risk doesn't give you the nuanced morphological picture of why the fetus might be struggling. And understanding the why is absolutely vital for comprehensive pretest counseling before we ever pick up a needle.
I see the deep logic in building that comprehensive clinical picture. I really do. But we have to return to the primary fundamental directive of any public health screening program.
Which is?
Identifying the target condition with the absolute highest possible sensitivity and the lowest possible false positive rate. The physiological mechanics just don't lie. Cell-free DNA's near-perfect sensitivity and incredibly low false positive rate make it the undeniable primary screening tool for genetics.
For genetics, perhaps.
It elegantly replaces older, noisier biochemical models. We can and absolutely must continue to perform rigorous anatomical ultrasounds, but using a statistical algorithm based on fluid and bones to guess at a genetic karyotype when we can literally sequence the placental DNA circulating in the mother's blood is holding on to the past.
And I will always maintain that the 11 to 13-week ultrasound is not the past. It is an irreplaceable, deeply integrated clinical platform. The rich morphological and hemodynamic data it provides is the only thing that protects our patients against the structural blind spots of genetic sequencing.
Even with its higher false positive rate.
Yes, because we aren't just looking for 3 copies of a chromosome. We are dynamically evaluating a complex fetal cardiovascular system. Relying solely on the genetic precision of maternal plasma risks reducing a highly complex developing human being to nothing more than a genotype. And in doing so, we miss the critical, life-saving phenotypic realities that only the ultrasound suite can reveal.
Well, we have certainly highlighted the deep tension between these two philosophies today. Genotype versus phenotype. Lab precision versus clinical holism. But it is worth noting exactly where the modern evidence forces us to agree.
Yes, we do have common ground.
Whether a clinician follows the newer cell-free DNA first pathway of ACOG or the traditional integrated ultrasound pathway of ICOG, 2 absolute truths emerge. First, the diagnostic procedure loss for CVS and amnio is now safely quoted below 0.5%, which fundamentally changes how we counsel our patients.
And second, an early anatomic survey remains absolutely not negotiable. Whether you draw maternal blood to sequence fragments or you calculate a combined risk score based on markers, you must physically look at the fetal anatomy. The technology evolves, but the fundamental obligation to visualize the developing fetus remains constant.
The sheer complexity of modern fetal medicine is awe-inspiring. We are looking closer and earlier than ever before. And we have really only scratched the surface of these guidelines today.
There's so much more.
There's so much more physiological depth to explore, from how we adjust these exact algorithms for the shared placentas of twins, the chorionicity adjustments, to the entirely separate but equally vital realm of measuring uterine artery blood flow to screen for early preeclampsia.
It is a constantly shifting landscape. And what we find time and time again is that every time we improve our genetic resolution, we realize we need our functional morphological resolution to be just as sharp to make sense of it all.
Which leaves us right back at the central tension we started with. Do we trust the clean, binary, molecular precision of a lab test to guide our hands? Or do we embrace the murky, complex, functional reality of the developing human in the ultrasound suite? We will leave you to weigh the evidence and draw your own conclusions.